And that's just a cartoon of a normal pulmonary vessel and a pulmonary vessel in someone who has scleroderma and now has pulmonary arterial hypertension, where there is intimal thickening and the vessel is occluded. As you can see, if you measure gas exchange in people who have this kind of appearance, these people will have resting hypoxia and an elevated alveolar to arterial oxygen gradient. There's a marked reduction in diffusion capacity also because there's thickening of the blood gas barrier, which is the interstitial thickening, and there's ventilation-perfusion mismatch, which is more evident when these people are asked to walk around. So what's the test you're going to do? You're going to do a diffusion capacity of the lung for carbon monoxide that measures the integrity of the blood gas barrier. You can ask them to exercise in what's known as a 6-minute walk test, where we put a pulse oximeter on our patients and we ask them to walk down the hall for 6 minutes, and we measure the distance and their saturation of oxygen while they're doing that. You can do resting blood gases, and you can ask them to walk around and do a blood gas after exertion. This is a table taken from a report in one of the rheumatology articles that looks at the prevalence of abnormal pulmonary function tests in patients with scleroderma. And you can see that the majority of people will have a restrictive impairment. Some of them will have this impairment either because they've got interstitial lung disease and associated secondary pulmonary hypertension, but some of them will have isolated pulmonary hypertension, and they will have an isolated reduction in their diffusion capacity of oxygen, i.e., there is impairment of gas transfer. If these people have smoked, then they're more likely to have a mixed obstructive component. I can't talk about lung disease without speaking a little bit about the histopathological ways that these present. The most common way is the interstitium, as we've been talking about, and there's a number of mnemonics that we use. Basically, interstitial involvement is divided into two kinds. One, which are called the interstitial pneumonias, which can present either acutely or chronically, and two, the alveolar damage that is seen as the clinical presentation of acute respiratory distress syndrome. Another way for the connective tissue diseases to present is as an intrinsic airway disease, and this is either as bronchiectasis or as a bronchiolitis of different kinds. Pulmonary vascular disease is seen when there is a vasculitis, usually a medium small vessel vasculitis. Occasionally, some of these, such as lupus, will present with a capillaritis and alveolar hemorrhage. Venous thromboembolism, either due to an antiphospholipid antibody syndrome or in situ thrombosis, or a DVT with a pulmonary embolism due to mobility can be one way that they present. There's also non-inflammatory obliterative vasculopathy that we see most commonly in scleroderma. Extrapulmonary disease. Arthritis of the respiratory cage joints, weakness of the respiratory muscles, obesity due to decreased mobility, decreased corticosteroids will all lead to dyspnea. Pleural disease such as rheumatoid and lupus, or bulbar muscle weakness such as in dermatomyositis and polymyositis can lead to aspiration pneumonias. So these are the various pathological ways that this develops. But how do they present clinically? Well, one way is when there's an asymptomatic radiological abnormality. This is an X-ray that shows you a blunted right angle. This can be due to small pleural effusion or the visual pleural thickening from pleuritis. But also, if you have rheumatoid nodules, if you have an early stage of interstitial fibrosis or the effusions, it can look like this. Another way of presentation is when these people have an acute presentation, when they end up in the hospital or they end up in the intensive care unit. And that's an acute pneumonia-like presentation with dyspnea, diffuse infiltrates, and fever, an X-ray that looks like this with bilateral alveolar infiltrates. And that can be the acute presentation of the pneumonitis, the inflammatory pneumonitis, the diffuse alveolar damage, or the cryptogenic organizing pneumonia, what used to be formerly called BOOP. Infective pneumonias will also present in this way, as with alveolar hemorrhage and secondary cardiogenic pulmonary edema from lupus myocarditis. Another way that you may see these people in clinic is when they have dyspnea and a normal chest x-ray. One reason for that is isolated pulmonary artery hypertension, as in scleroderma. And this is a CT scan that shows you dilated proximal pulmonary vessels with pooling of the periphery of these vessels due to obliterative arteriopathy in the peripheries. Another way they present is when they've got muscle weakness, such as in polymyositis. This is a picture of subluxation of the cricoarytenoid joint. You can see the true vocal cords in the distance, and this is seen in people with rheumatoid arthritis when they present with upper respiratory symptoms of a foreign body in their throat, a sore throat in the morning, stridor, dyspnea. Acute onset of shortness of breath with a normal chest x-ray. Always think of the acute reversible hypoxemia syndrome, which is due to complement activation in the lungs, or a pulmonary embolism. This is a spiral CT scan with contrast in the pulmonary vessels. This is the right main pulmonary artery, and you can see the filling defect right here, and this is a large clot which is occluding the right main pulmonary artery. This is a matching perfusion scan where you can see that there is perfusion on the left side and no perfusion in the entire right lung. Sometimes people will present with hemoptysis, which comes from rheumatoid nodules that cavitate, from telangiectasias, or from bronchogenic cancers. And the most frequent presentation, which is of shortness of breath, dry cough, bibasilar, fine Velcro creps, which is the chronic interstitial lung disease presentation of bilateral lower zone fine interstitial markings, and on the CT scan, interstitial prominence with honeycomb lung. And lastly, an acute presentation of pleuritis with chest pain, fever, dyspnea, sometimes due to pneumonia and associated effusions, and sometimes due to